The topic for today's lecture is neonatal conjunctivitis. I'll be covering causes, diagnosis, and treatment. Starting with introduction. Neonatal conjunctivitis, or ophthalmia neonatorum, is defined as conjunctival inflammation developing within the first month of life. It is the most common infection of any kind in neonates, occurring in up to 10%. It is identified as a specific entity distinct from conjunctivitis in older infants because of its potentially serious nature, both ocular and systemic complications, and because it is often the result of infection transmitted from mother to infant during delivery. Uh, Causes include organisms acquired during vaginal delivery. Uh, these include chlamydia trachomatis, Neisseria gonorrhea, which is now rare in wealthier countries but previously reports responsible for 25% of childhood blindness, and herpes simplex virus 2. With all of these, conjunctivitis is not uncommonly associated with severe ocular or systemic complications. Chlamydia trachomatis is the most common cause in cases involving moderate to severe conjunctival inflammation. Then is staphylococci, which are usually responsible for mild conjunctivitis. Other bacterial causes include streptococci, H. influenzae, and various gram-negative organisms. Topical preparations used as a prophylaxis against infection may themselves cause conjunctival irritation, and it is termed as chemical conjunctivitis. Then is congenital nasolacrimal duct obstruction, which, despite poor neonatal tear production, a persistent mild watery eye with recurrent mild bacterial conjunctivitis may be secondary to a blocked tear duct. Now, diagnosis is dependent on different factors. The first one is timing of onset. Uh, Chemical irritation causes conjunctivitis in first few days, while the gonococcal infection causes symptoms in first few weeks, especially in the first week. Staphylococcal and other bacteria cause in the end of first week, herpes simplex virus in 1 to 2 weeks, and chlamydia in 1 to 3 weeks. Next important factor for diagnosis is history. Installation of a prophylactic chemical preparation, parental symptoms of sexually transmitted infections, STIs, recent conjunctivitis in a close contact, and features of systemic illness in the child, pneumonitis, rhinitis, and otitis and chlamydial infection, skin vesicles and features of encephalitis and herpes simplex virus. Disseminated gonococcal infection is relatively rare. Prior persistent watering without inflammation may indicate a nasolacrimal duct that is not yet open. Signs include a mildly sticky eye, which may occur in staphylococcal infection or with delayed nasolacrimal duct canalization. Mucopurulent reflux on pressure over the lacrimal sac can be observed. Discharge is characteristically watery in chemical and herpes simplex virus infection, mucopurulent in chlamydial infection, purulent in bacterial infection, and hyperpurulent in gonococcal infection. The discharge seen in the picture here seems to be purulent, and it can be hyperpurulent, but we cannot say it with certainty. Severe eyelid edema in gonococcal infection is observed. It may be difficult to distinguish severe conjunctivitis from preseptal or orbital infection. Signs of dacrocystitis should be excluded as well. Eyelid and periocular vesicle may occur in herpes simplex infection and can critically aid early diagnosis and treatment. Corneal examination is mandatory and is particularly important if gonococcal infection is suspected, as ulceration with rapid progression is common. Use of a pen torch, insertion of an eyelid speculum, and fluorescent drops may be helpful. The latter may facilitate identification of a dendritic or geographical epithelial lesion that may be present in herpes simplex virus infection, in contrast to punctate epitheliopathy seen in older children with primary herpetic conjunctivitis. Pseudomembranes are not uncommon in chlamydial conjunctivitis. Congenital glaucoma may masquerade as neonatal conjunctivitis and should always be considered, particularly in monocular cases. Investigations are tailored to the clinical picture. The results of any parental prenatal testing for STI should be obtained. Conjunctival scrapings are taken for nucleic acid amplification (PCR), particularly for chlamydia and HSV. Separate conjunctival scrapings are applied to a glass slide for Gram and Giemsa staining. Multi-nucleated giant cell may be present on Gram stain in HSV infection. Conjunctival swabs are taken with a calcium alginate swab or a sterile cotton tip applicator for standard bacterial culture and chocolate agar or Thermartin for Neisseria gonorrhea. Epithelial cells infected with HSV may show eosinophilic intranuclear inclusions on Pap smear. Conjunctival scrapings or fluid from skin vesicles can be sent for viral culture for HSV. Specimens should be taken prior to fluorescent installation if immunofluorescent testing is planned. Coming towards treatment, prophylaxis is routinely performed, but there is no standard protocol. A single instillation of povidone iodine 2.5% solution is effective against common pathogens. Erythromycin 0.5% or tetracycline 1% ointment. Silver nitrate 1% solution agglutinates gonococci and is still utilized in areas where gonococcal infection is common. It should be administered in conjunction with a single intramuscular dose of benzyl penicillin when maternal infection is present. Chemical conjunctivitis does not require treatment apart from artificial tears. Mild conjunctivitis, a mildly sticky eye, is extremely common in neonates. Investigation is often unnecessary, and a low intensity regimen with a broad spectrum topical antibiotic such as chloramphenicol, erythromycin, or fusidic acid ointment is adequate in most cases. Further investigation and treatment can be instituted if the condition fails to settle. Moderate to severe cases should be investigated. Microscopy with Gram staining alone is highly sensitive and will often provide a working diagnosis. If a diagnosis is uncertain but chlamydial infection is a reasonable possibility, oral erythromycin can be commenced on an empirical basis after samples have been collected. If bacteria are evident on Gram stain, a broad spectrum topical antibiotic, for example, chloramphenicol, erythromycin, or bicetracin for Gram positive organism, neomycin, ufloxacin, or gentamicin for Gram negative should be used until sensitivities are available. Additional systemic treatment should be considered in more severe cases. In cases of severe conjunctivitis or when systemic illness is suspected, uh, hospital admission is required. Samples should be taken for a range of investigations, including urgent microscopy and a broad spectrum topical antibiotic such as erythromycin is commenced. The ocular risk is usually most acute from gonococcal infection, so empirical topical treatment should cover this, and in most cases, consideration is given to systemic treatment such as parenteral ceftriaxone. Chlamydial infection is treated with oral erythromycin for 2 weeks. A longer or supplementary course may be needed. Erythromycin or tetracycline ointment can be used in addition, but is probably unnecessary. Gonococcal conjunctivitis is treated systemically with the third generation cephalosporin and often with supplementary topical treatment. Co-treatment for chlamydia is prudent. Saline irrigation to remove excessive discharge should be considered. Herpes simplex infection should always be regarded as a systemic condition and is treated with high-dose intravenous acyclovir under pediatric specialist care. Early diagnosis and treatment of encephalitis may be life-saving or prevent serious neurological disability, and PCR of CSF is positive in 95% of cases. Topical acyclovir may be considered in addition. In addition to all these measures, microbiological advice should be sought in severe cases, especially regarding local antibiotic sensitivities. Pediatric specialist involvement is mandatory when systemic disease may be present. Genitourinary referral for the mother and her sexual contacts is important. When an STI is diagnosed, the neonate should be screened for other STIs. Notification of a case of neonatal conjunctivitis to the local public health authority is a statutory requirement in many countries. So, we are concluding the topic of neonatal conjunctivitis here. If you like the lecture, please click on the like button and subscribe to the channel. Thank you so much.